morning. I would first like to thank Dr. Manohar Babu, Dr. Sunita, Dr. Anuja, and the whole Salem team for inviting me for this CME. So today I'll be speaking on Adnexal and orbital infections. So as ophthalmologists, our main concern is cataract, and as cataract surgeon, our main concern is to have a best visual outcome. So we have to take every small step to bring the best visual outcome for the patient. So whenever we examine a cataract patient, we mainly focus on the lens or the cornea or the retina, and many times we ignore the lids, tear ducts, and any orbital pathology or any adnexal pathology. So it should be borne in mind that the ocular adnexa can also affect the outcome of cataract surgery, and the most dreaded complication for any ophthalmologist would be an post-cataract endophthalmitis. So first, I will be dealing with some of the eyelid infections. So coming to blepharitis. So the most common cause for postponing a cataract surgery would be blepharitis. So this will be like anterior blepharitis, and which can be staphylococcal or ulcerative, or seborrheic, which can be squamous or seborrheic or squamous. So this can lead to tear film instability, dry eye, corneal punctate erosions, and also bacterial keratitis. So you can see this patient here, he has severe blepharitis. It's mostly like an ulcerative blepharitis. So where when you try to peel it off, it starts bleeding. So this is again posterior blepharitis, otherwise it's called as an MGT. So what are the issues faced by these patients? They have an irritated eye, and after surgery, they have a longer duration of inflammation in the eye, especially after any cataract surgery, poor visual outcome after cataract surgery, and high risk of postoperative endophthalmitis. So we have to first treat these patients with warm compress and lid hygiene, antibiotic or antibiotic steroid ointment, artificial tears to elevate the dry eye, and oral doxy can be given in recalcitrant cases. So when would you perform a cataract surgery, or what is the time interval? So you wait at least for 3 weeks before starting the surgery and perform a bacterial culture from the conjunctiva and from the lid and start pre-op topical antibiotics. This though it's not an infection, it's a sterile granulomatous inflammatory lesion of the meibomian glands, but this was again one of the very common causes for postponing of the cataract for any intraocular surgery, either cataract or retinal or any corneal surgery. So mostly it's like either blepharitis or chalazion. So this is, you can see here, there's a large chalazion here, and the patient with a cataract again with chalazion. So most of the time these cases, and this is again a patient with an infected chalazion here. So these are the common causes for postponing. And this is again a hardiolum internum, which is, you can see it's a acute staphylococcal infection of a meibomian gland. And this, they present with a tender swelling of the eyelid, and they usually either discharge through the skin or through the conjunctiva. And this, you can see hardiolum externum is another very common infection. Here, it's a staphylococcal infection of the gland of size, and they usually present at the lash follicle or at the lid margin, and they present as a very tender swelling at the margin. So treatment is hot fomentation, topical or systemic antibiotics. You can epilate the lash to prevent for the drainage of the pus, and non-resolving, you can do an INC. So again, for these cases also, you wait at least for 7 days after resolution, perform a culture, and also give it pre-op topical antibiotics. Next is lacrimal abnormalities. So here you can see again in the lid, you can see there is small pouting here. So what is this? Here, usually when you do a syringing, the duct will be free, but you can see there's a pouting, and the Roplus is usually negative. And most typically, you can have a pouting punctum. So this is caused by actinomyces israeli, and the diagnostic clue would be a pouting punctum. Treatment would be, you can just make a small snip at the punctum, and you can just curate the concretions and give topical antibiotics for 2 weeks prior to any intraocular surgery. And another common condition is dacryocystitis. You can see these patients who came with a lot of discharge and with cataract, and you can hear there's also swelling over here. And how do you treat this? Sorry, wait, just a minute. Yeah. So when it's acute, you give oral or IV antibiotics. Sometimes they even present with preseptal cellulitis. So you give anti-inflammatory and warm compress. Chronic dacryocystitis, better to do a DCR before the surgery. So coming to next is orbital cellulitis. So they are bacterial orbital cellulitis. And so any pathology in the orbit is like a Pandora's box. And even orbital cellulitis is again is similar to that. So it's acute spread of infection to soft tissues of the eye behind the orbital septum. So the etiology and risk factors could be either exogenous or most common in children is spread from the ethmoid sinuses, especially in children. It can also occur as an exogenous due to trauma. Endogenous could be because of bloodborne, especially in septic endocarditis, or it can occur in immunocompromised patients who are on long-term steroid or any immunocompromised drugs or immune drugs. So agents in children, most commonly it's Staph aureus or strep and anaerobes. Adults, it's again the same, similar, but with E. coli and mixed flora. Fungi can be aspergillus or mucus, and most commonly fungus occurs in diabetic and immunocompromised patients, and sometimes you can even get parasites like Taenia solium, Echinococcus, Trichinella, and Toxoplasma. So pathophysiology of these agents, they cause thrombophlebitis and necrosis of the tissues. They actually cause inflammatory reaction which leads to thrombophlebitis and necrosis, and they cause tight compartment in the orbit, and because of absence of lymphatic, it leads to necrosis of the orbital tissues. So these are the main, I said, it actually spreads the same thing, spread of inflammation from surrounding as thrombophlebitis causes extensive tissue necrosis. Owing to the tight orbit, it can easily increases the inflammatory changes. And because of absence of lymphatics and limited defense mechanism, it makes the orbit more prone to infections. So 85 to 95% of orbital cellulitis, the source is rhinosinusitis, ethmoid sinusitis, and pansinusitis. So how do they present? So symptoms commonly are swelling of the affected area, painful restriction of extraocular movements, diminution of vision, fever, nausea, vomiting, and prostration. And signs would be lid edema, proptosis, chemosis, restriction of extraocular movements, and raised intraocular pressure. So what are the complications of these orbital cellulitis? So usually Chandler has classified orbital cellulitis into 5 types. One would be preseptal, and then which could progress to orbital, and you leave it like that. You can go to subperiosteal abscess or orbital abscess, or to finally cavernous sinus thrombosis, which is the most dreaded complication. So what is preseptal cellulitis? It is swelling of the iris and structures anterior to the orbital septum. So here you can see in the MRI, the swelling is only anterior to the septum. The orbit is clear. Sorry. So here, how do you differentiate this? They don't have proptosis. The pupils are reacting normally. Vision is normal, and extraocular movements are full. That's how you differentiate it from orbital cellulitis. Whereas orbital cellulitis is infiltration of the orbital tissue causing varying degrees of edema. Proptosis is always present with chemosis, restriction of ocular movements, and most of the patients have diminished vision. So here you can see this is the eyeball, and there's almost all of the orbital tissues, sinuses, maxillary and ethmoid sinuses involvement. Subperiosteal abscess, this is a collection of pus between the periorbita and bony wall, and it is characterized. Here you can see this is a periorbita, this is a bony wall, and this is the periorbita. The pus will never take up any contrast, so it usually appears hypointense on the scan. And they cause localized tenderness over the abscess area. Usually it's a complication seen in sinusitis. Next, coming to the orbital abscess, this is a collection of pus either in intra or extracorneal compartment of orbit. Visual loss may be severe in these cases. So you can do an orbital ultrasound which shows low reflectivity in abscess. CT scan again shows a homogeneous periorbital elevation and opacified. You can see these are the These are the opacified sinuses. So this patient had orbital cellulitis because with the secondary to the sinusitis. And the cavernous sinus thrombosis is one of the, it's not only vision threatening, it's also a life threatening condition. And these patients can present with headache, vomiting, nausea, and altered sensorium, and with multiple cranial nerve involvement. And whenever the patient with the unilateral goes for a bilateral involvement, always suspect a cavernous sinus thrombosis. So other sight-threatening complications would be permanent visual loss, and now it's uncommon because of antibiotics and orbital awake syndrome, compressive optic neuropathy. Patients can even go for CRAO, CRBO, secondary glaucoma, and exposure keratopathy. So all this, whenever patient comes with orbital cellulitis, you have to check for these signs. And other life-threatening complications could be osteomyelitis, which could be either due to direct invasion or indirectly via blood-borne, that is septic thrombophlebitis. And intracranial complications can be meningitis, or the patient can develop an intracranial abscess. So what would be the differential diagnosis of an orbital cellulitis? So sometimes we were not sure whether it's an orbital cellulitis or whether it can be a pseudotumor. Sometimes these patients also present with the same features like proptosis, chemosis, pain, and restriction of ocular movements, and sometimes also with mild loss of vision. So you have to differentiate them also, like pseudotumor, acrodenitis, orbital retinoblastoma, rhabdomyosarcoma, neuroblastoma, retrobulbar hemorrhage, cavernous fistula, and orbital foreign bodies, vaginous, sarcoidosis, and sometimes acute thyroid eye disease. So coming to management. So you do the routine blood tests like, bacterial blood culture is done in any orbital cellulitis, bacterial cultures, nasal swab, sometimes lumbar puncture. And radiological tests would be X-ray, PNS, ultrasound, CT, and MRI, CT or MRI. MRI you need to do if you are suspecting any optic nerve involvement or it has gone to the cavernous sinus. Otherwise, CT is more than enough to pick up these findings, or venogram. So again, the treatment is always a challenge for the surgeon or for the treating surgeon. So if the patient is unwell or no unwell, you all with proptosis and decreased vision, and patient presents with pain of orbital swelling, you manage as sepsis, as an orbital cellulitis. So if the patient is less than 3 months of age with significant swelling, you perform adequate eye examination and manage as severe periorbital cellulitis. Otherwise, if the patient has got only moderate swelling, then you can manage as a moderate periorbital abscess. But all the cases require hospitalization and management with IV antibiotics. So the drugs are like, a lot of drugs are there, but ideally we give third generation cephalosporin is better. And based on if the patient has got, we suspect MRSA infection, vancomycin can be added. And optic nerve involvement, or if there is any RAPD, better to go even for a corticosteroid. We can give corticosteroid, first initiate the antibiotic, IV antibiotic, and then you can go for corticosteroids. Most often we consult the pediatrician and then we start the treatment for these patients. So when will you go for surgical treatment? So whenever there is a suspicion of orbital or subperiosteal abscess or a foreign body, progression of visual loss, there is worsening of proptosis, and non-reduction in the size of abscess after starting antibiotic therapy. So how will you manage a subperiosteal abscess? So this is as a general recommendation. Garcia and Harris have observed that IV antibiotics alone is indicated whenever the child is less than 9 years of age, no intracranial involvement, and there's a medial wall abscess of moderate or small swelling or small size. There is no visual loss or no RAPD, and there is no frontal sinus involvement and no dental abscess. So these cases can be just managed medically, and there's no need for surgical management. So how do you do the surgical procedures? You can do a free incision onto the abscess wherever it's pointing onto the skin or conjunctiva. Subperiosteal abscess also can be drained. Usually it is a medial abscess, so near the medial orbital wall. And you can just put an like a DCR incision and just drain it. And brain abscess, of course, you have to refer it the patient to a neurosurgeon. And always get a ENT consultation for these kind of patients who ever have a sinus involvement. So what are the red flag signs? So whenever you see any painful or restricted eye movement, visual impairment, reduced visual acuity, afferent pupillary defect, diplopia, proptosis, severe headache, then always think of a orbital cellulitis. Lastly, coming to the orbital fungal infections. So these are most commonly orbital caused by mucormycosis, which is an aggressive angio-invasive disease, and it's an infection caused by fungal or other mucrales. And most common is rhizopus, where 70% of the cases are involved. And these fungi, they have a predilection to invade the blood vessels, causing infarction and necrosis. So recent times we know there's a rampant increase during COVID, especially of mucormycosis. So these are the incidents. So one in million in Western population, whereas in India it is 14 in 1 lakh, and it's very fatal because it has more than 50% mortality. And initially, okay, yeah, initially we were seeing actually 3 to 5 cases in a year, but during COVID we were seeing about 4 to 5 cases per week. So this is the pathogenesis, and here usually it's inhaled as spores, and they get trapped in the paranasal sinuses, and they usually cause, leading to ischemia followed by necrosis, and this can also spread to the orbit, causing extensive necrosis in the orbital tissues. So this I've already told. Nose to paranasal. Sinus usually is the first to get involved, followed by sphenoid and posterior-ethmoid, anterior ethmoid, and then also teeth, alveolus, and palate. From orbit, it can go to the cribriform plate and orbital apex, and then to the cavernous sinus. And usually, it's very rapid the spread, so it has a high morbidity and very high mortality rate. So, who are the population who are at risk of getting fungal infections? Mainly, they are patients with diabetes, with uncontrolled sugars, diabetic ketoacidosis, indiscriminate use of steroids, neutropenia, and high cytokine, especially patients with cytokine strong in COVID patients, patients on ventilator support, and immunocompromised patients, and patients with iron overload, and recently treated COVID-19 patients. So how will you classify? These are based on anatomic location. Just a few more slides. Like rhino-orbital mucormycosis, pulmonary, cutaneous, gastrointestinal, oral, and CNS. And of all these, the most common is the orbital mucormycosis, accounting for more than half the cases. They present mostly with periorbital swelling, here as you see, or numbness with eschar, pain in the eye, and they have severe headache, conjunctival chemosis, and you can see this eschar formation and proptosis, drooping of the lids here, and also blurred vision or sudden blindness. Diplopia, external ophthalmoplegia, RAPD, again the same as any tooth pain, periocular sensation decrease. And fundus examination, always look for most of the patients, the sudden loss of vision is because of CRAO. So again, these are the ENT symptoms which you have to ask. Always do ENT examination. You can see a black necrotic eschar on the nasal turbinates, which can lead to perforation, and also a hard palate or palatal perforation. And these are the general symptoms like fever, headache, shortness of breath. And whenever there's intracranial invasion, they have mental disorientation, seizures, and hemiparesis. And these are the all the blood tests which we do as for a orbital cellulitis, along with RF renal function test and HbA1c and liver function test. And these are, I think, already been dealt by Ram sir, by how do you diagnose, and also by the previous speakers, doing a biopsy, cultures, and this is again by histopathology. And imaging will show non-enhancing black turbinate sign, which shows opacification of paranasal sinuses. And early stages, there'll be enhancement of the medial wall or medial rectus enlargement. Advanced stages, there's a diffuse orbital involvement reaching the orbital apex with lack of enhancement because of necrosis. Again, this involves a multidisciplinary approach with intravenous amphotericin B, preferably liposomal, and with prompt surgical debridement of the sinuses and the facial debridement plus or minus accentration. So we usually send these cases to an ENT surgeon or to a multi-specialty hospital because they require frequent blood investigations every 3 days for, especially when they're on amphotericin. Orbital excentation is not an indication when the patient has just got ptosis, ophthalmoplegia, or loss of vision, but factors to be taken into consideration before excentation would be amount of orbital involvement, amount of necrosis, orbital apex, and intracranial extension. Then you need to think of excentation. Summary, whenever you see a case of fungal orbital cellulitis, you have to have a high degree of suspicion, clinical radiology diagnosis, and a triad of ophthalmoplegia, sinusitis, and CRO, biopsy confirmation, early debridement with antifungals, and retrobulbar amphotericin in select cases. And there's a limited data on the treatment with retrobulbar amphotericin. So this is the triad, which I said, ophthalmoplegia, sinusitis, and CRO. Thank you.